Good evening, and welcome to AUA's latest breakthroughs in low-grade intermediate risk NMIBC 2025 live virtual course. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we can continuously improve our programs. The AUA is accredited by the ACCME and designates this live activity for a maximum of 1.50 AMA PRA Category 1 credits. Course handouts from the presentations have been made available to you. Please visit AUA University to access the handouts. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on AUA University immediately following the course. As we at the AUA continue to develop virtual education that meets your needs, we especially welcome your feedback regarding both the content and format following this program. As the ACCME accredited provider, all financial relationships with an ineligible company, formerly commercial interests, during the previous 24 months. An ineligible company is defined as one whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. The AUA must determine if the individual's relationships are relevant to the educational content and mitigate any conflicts of interest prior to the commencement of the educational activity. The intent of this disclosure is not to prevent individuals with relevant financial relationships from participating, but rather to provide learners with information so that they can make their own judgments. Coding advice given during presentations are the opinion of the presenters and may not have been vetted through the AUA for accuracy. Please verify accuracy prior to reporting on medical claims. You are prohibited from using or uploading content you accessed through this activity into external applications, bots, softwares, or websites, including those using artificial intelligence technologies and infrastructures, including deep learning, machine learning, and large language models and generative AI. The AUA would like to thank Eurogen Pharma Inc. for providing an independent educational grant in support of this activity. Finally, I'd like to introduce and extend a special thank you to our course director, Dr. Bogdana Schmidt, for her time, talent, and expertise in developing this program. Dr. Schmidt is a urologic surgeon at the University of Utah in Salt Lake City, Utah. She specializes in urologic oncology. Dr. Schmidt attended the University of California, San Francisco School of Medicine and stayed to complete her residency training there as well. She then completed a Society of Urologic Oncology Fellowship at Stanford University. I will now turn the course over to Dr. Schmidt.
Thank you very much. It's a pleasure to be here and join you all this evening. The goal of this activity is to update the urologic care team on the latest advancements in low-grade intermediate risk non-muscle invasive bladder cancer treatments. Our learning objectives include applying updated clinical evidence and treatment protocols for low-grade intermediate risk non-muscle invasive bladder cancer to improve clinical decision-making related to risk stratification, support evidence-based patient-centered treatment selections, interpret the efficacy and safety profiles of new therapies, and assessing the impact of treatment options on patient-reported outcomes, including quality of life and treatment burden, to help guide shared decision-making and optimize care delivery for our patients. And now I'd love to introduce our subject matter experts joining us this evening for this session. Dr. Aaron Leviana is an assistant professor in the Department of Surgery and Perioperative Care at Dell Medical School. He's a urologic oncologist who specializes in bladder cancer, kidney cancer, prostate cancer, testicular penile cancers, and complex kidney and robotic surgery. Meredith Donahue is a nurse practitioner at Vanderbilt University, specializing in urologic oncology. She manages a non-muscle invasive bladder cancer clinic, which involves installation of intravesical therapies, as well as managing all their side effects and advocating for patient cancer survivorship. Along with this, she closely co-manages the advanced prostate cancer patients in the Comprehensive Prostate Cancer Clinic, and this clinical focus has dovetailed into a collaboration with Vanderbilt University Medical Center, Medical Oncology, and the Hereditary Cancer Clinics. And lastly, we have Dr. Pauline Filippo. She's a urologic oncologist with the Permanente Medical Group in Kaiser Permanente, Northern California, and an affiliated clinical assistant professor in the Department of Urology at Stanford University. Thank you all so much for joining me this evening. Without further ado, we're going to get started by discussing a patient example. So this is a 76-year-old gentleman with hypertension, COPD, AFib on warfarin with a 4-year history of recurrent low-grade non-muscle invasive bladder cancer who underwent induction gemcitabine, then recurred. 2 years later, he underwent induction BCG and got 1 cycle of maintenance until a shortage started and he was transitioned to surveillance only. He's had 6 TURBTs and has been admitted twice for gross hematuria and clot retention in the past. He now presents for surveillance cystoscopy, and you see 4 small, low-grade appearing tumors in his bladder. Pauline, does this patient sound familiar?
Yeah, absolutely. I think this patient and patients like him are very common in our practice. And I think low-grade non-muscle invasive bladder cancer in general is kind of a clinical conundrum for a lot of urologists because we know that the biologic signature of the disease portends a pretty low chance of progression, but like this patient, they come back with recurrence so often. And although treating and managing these patients helps prevent that recurrence in some situations, we're not affecting kind of the overall survival of the patient because of the nature of the disease. And I think a lot of our treatments and surveillance can create a lot of downstream effects for the patient, as this patient had, hematuria, clot retention, admission to the hospital after one of his multiple TURBTs. So this is a very common patient in my practice, and I'm sure a lot of people's practices.
Absolutely. I completely agree. And if this patient walked into your practice a year ago, a patient like this one, what would your conversation look like for him at this stage? He's had these experiences, he's had these he currently has another recurrence, unfortunately. What would your treatment plan conversation look like?
Yeah, I think a year ago, I think a lot of the conversation has traditionally stemmed around TURBT. So going back to the operating room for resection. I think in the last year and recently, because of new therapies and technologies, which we'll talk about today, there may be some options for other counseling that we'll talk about extensively. And I think also there's been a bit of a push for active surveillance in some of these patients, depending on what the size of the tumor is, how many of them, the signature in terms of what's been happening in terms of pathology in the past. You could either not treat or plan to fulgurate or treat even in the office in some situations. So usually TURBT is first considered, but I think now we're coming up with other ways that we can treat these patients.
And Erin, if a similar disease pathology happened to be in a younger, otherwise healthier patient, same tumor profile, but 52-year-old patient, any difference in how you would approach them at that point?
Yeah, I mean, it's a very common problem we're encountering now. If you think of 80,000 patients annually are diagnosed in the US with bladder cancer, 25,000, give or take, fall into this sort of intermediate risk category that this patient falls into. So there's quite a few here. And, this is becoming more of a chronic disease than it is a lethal disease. And I think that's really important to talk when counseling with these patients here. As a 52-year-old, life expectancy otherwise could be on the magnitude of decades here. Are you going to take them to the operating room every time we all have those patients when you talk to them about TURBT, the first thing they say is please no catheter afterward, and yet there can be complications there too. So I think just the goals of care with them is critical to determine, are they comfortable with active surveillance? There's more and more data showing the legitimacy of that, versus absolutely not. They want this either fulgurated in the office or taken back for TURBT. And I know we'll get into some of these trials in a bit too, but all these emerging technologies as well. I just think it's critical that we just don't have a narrow lens or a myopic view on this, and just really present all these options in terms of what best matches with their preference.
Absolutely. I think it's very important to really have the conversation with the patient and engage in shared decision making, especially when there are more options that enter the landscape. On that note, Pauline, how do you define success in this population? You mentioned earlier that these patients thankfully don't progress frequently to a more deadly form of bladder cancer. And so what does success really look like? Is it trying to reduce recurrences, or is it trying to reduce the amount of time they have contact with the healthcare system overall? Because sometimes those two things can be at odds with one another.
Yeah, absolutely. So I think all of the above, right? Like Erin was mentioning, figuring out what the goals of the patient are, where they prioritize their, bladder cancer journey looking like down the future, and that changes based on so many different things. But I think uh, high value care to me is patient centered, figuring out what they want. Yes, minimizing recurrence as much as you can, but also minimizing trips to the operating room, minimizing anesthesia sessions, in some ways, minimizing cystoscopies down the road for surveillance if it's appropriate. Giving therapy where it's needed, but when there's data potentially supporting it's not needed, not escalating. So we walk a fine line in treating these patients in a patient centered way.
Absolutely. It's certainly a lot to consider for us and obviously for our patients as well. Meredith, how does treatment choice impact how patients feel about this in terms of anxiety or inconvenience? So you're saying the patient can choose to have their TURBT resection, and then we'll say, well, we can do surveillance, come back in 3 months. If a little thing comes back, we can burn it off in the clinic, versus we can say, well, that was an uncomfortable experience for you last time. Let's see if we can reduce a recurrence by having you come back 6 times to the clinic. How do you think patients make these decisions? Because I find it very challenging to help a patient make those decisions. So in your experience, what factors do you think they lean on?
Yes, I agree. It can be really challenging to get them to a decision. Oftentimes we lay out absolutely every option for them, and they say, "Well, what would you do? What would you do if I was your dad? What would you do if I was your mother?" Um, I think as providers, it can be easy for us to forget that the energy and time and resources that some patients need to be able to go to the operating room or to come once a week for 6 weeks, whatever it might be. And of course, we're always going to choose the therapy that or recommend the therapy that is best suited for that patient's disease state. But keeping in mind that every patient is going to be really different. If I've learned anything, that some patients they absolutely hate going to the OR and getting a TRBT. Some patients, they absolutely hate coming in once a week for 6 weeks. So trying to guide them in or guide yourself in what the patient is actually saying. And where I spend a lot of my time is also what other symptoms do they have? Do they go into clot retention every time they get a TRBT? Are they a postmenopausal woman and they're getting recurrent UTIs every time they get a urinary or every time they get a catheter? Are
Mhm.
they on anticoagulation? All of those things can contribute to our decision and helping the patient make that best decision for themselves.
Absolutely. Well, let's try to make things a little bit more specific. Let's try to talk about a specific patient scenario and how we navigate this. So, this is a 72-year-old man. He's a current smoker. He has hypertension, coronary artery disease. He was diagnosed with low-grade NMIBC, now presents for surveillance cystoscopy 1 year later, and he's got 5 papillary lesions. They're all under a centimeter each. So, Erin, could you start by walking us through the definition of this patient's risk stratification and how you think about that?
Yeah, so if you look at our AUA guidelines here, you classify it into low, intermediate, and high risk here. The intermediate risk is almost this gray heterogeneous zone in between the low and the high risk. The low is going to be just your low grade, very superficial TA tumor under 3 centimeters. And then the high risk are going to be, as you can see in this chart here, anything high grade T1, high grade refractory. And so in between all that is this sort of heterogeneous zone that's called intermediate risk. So by definition here, I always tell my trainees and everything, it's almost a diagnosis of exclusion. But these are going to be your recurrent low-grade TA tumors when the recurrence is under 12 months, or if you have a solitary tumor that's greater than 3 centimeters in size. They're oftentimes multifocal. It's almost like a dandelion, I'll say sometimes, that they can pop up all over here. You can also have, for the AUA guidelines, high-grade TA less than or equal to 3 centimeters. Then the last one here, which we see, I would argue very infrequently in practice, is this low-grade T1. But there is probably a difference here between something that is low-grade T1 and a very small, maybe multifocal low-grade TA.
I agree with you. I think the low-grade T1's a really interesting entity and overall really a pretty small slice of it. And my experience has been that when you see that low-grade T1, it's a really good patient to have a pathology review requested on, or having a GU pathologist specifically look at it, because if there is that invasive behavior, it might be a higher grade tumor. Or maybe you're looking at a variant histology or something that may change the way you approach that patient population. What about the high grade TAs that are around the 3 centimeter mark? How do you treat those as the same recurrence potential as a couple low grade TAs?
Yeah, no, that's a great question there too. I think similar to the low grade T1 with invasion into the lamina propria, if you look at the European guidelines here, they actually classify the high grade TA as a higher risk category for similar reasons, with the logic there being that the biology of these is probably more aggressive. So I will see this more frequently, but when I see that too, I will lean more toward the treatment side of things than with these other ones.
Yeah, I agree. I think that's how I think about them as well. And I think the IBCG risk stratification can be helpful here as well. Pauline, can you walk us through this about how you can use additional risk stratification tools to help guide decision making in this patient population?
Yeah, absolutely. So, like Erin was saying, this catch-all low grade intermediate risk um, group of patients can be difficult to manage because you're not sure if you're supposed to be giving BCG or intravesical therapy or nothing. And so the IBCG, the International Bladder Cancer Group, put out a consensus definition and management recommendations addressing this group. And they listed these 5 additional risk factors that can help kind of dictate additional intravesical therapy needs. So the risk factors that they have, and I think it is worth going through these, is multifocality, an early recurrence within a year, frequent recurrence of more than one a year, a large tumor greater than 3 centimeters, and then failure of any prior intravesical treatment. And basically, with none of those risk factors, they recommended just doing TURBT with your single postoperative intravesical chemo. With 1 or 2, they recommended intravesical chemo, and then with 3 or more, considering induction with something like BCG, followed by a year of maintenance if it's available. So I think this can help risk stratify and determine further intravesical therapy really nicely.
I agree. I think any little bit helps in this patient population to gain a little bit of clarity because, like Erin said, there's such a catch-all basket here that using risk factors to help guide and frame this for us as clinicians, but also for patients, can be really useful. One of the things that I'll often say to patients to sort of lay their fears with a cancer diagnosis and say, look, this is very rarely a deadly disease. This is a disease that you are going to live with and die with, unlikely to die from. However, these tumors can come back and they can become a nuisance, and you and I are going to get to know each other, and we sort of have that whole conversation. What I've discovered is once I tell patients that this cancer isn't going to kill them, that immediately decreases their patient's motivation to come back and see me sometimes. And I see that sometimes you'll have a real loss to follow-up, especially once it's been, a couple surveillance cystoscopies that look pretty good. I'll find that the patient will call and schedule, cancel, reschedule, things like that. So Meredith, how do you encourage patients to keep coming back and keep representing the care in this population? Or maybe no one else has this issue.
No, that can definitely be an issue. Obviously the big barriers are the number of treatments, the number of cystoscopies. I mean, I know at my institution, we have patients coming from 4 or 5 hours away to get,
Yeah.
especially in the BCG shortage, we're really seeing that. So there's a lot of barriers to it. And I think just in one thing, an important point to make is making sure your patients know the difference of progression versus recurrence. Because we throw those words around, but making sure they understand, like you said, this isn't going to kill you, but this will be something you won't kill you, something you die with. Kind of like how we talk about low risk prostate cancer on active surveillance. I find I don't think we have as much canceling and not coming back. Once patients understand it's not going to progress, it could very well recur. And I think a lot of people just understandably, don't like the idea of there is or there could be cancer in my body, whether it's going to be harmful to them or not. They don't want it there. And I think making sure they understand, yes, it could recur, and that means we go down this line again.
And I think this is also an important thing to discuss is these things,
Yeah.
like you said, they're not necessarily going to progress, but they could recur. And those recurrences can be symptomatic. Patients can develop hematuria. Patients can end up in the emergency room. All of those things can be a concern here. And I wanted to give you an opportunity, Pauline, just to emphasize, based on the IBCG stratification here, what those numbers really look like for our patients.
Oh, yeah. So again, this is going back to their using the risk factors to determine the chance of recurrence and progression. And so again, you see, that with no risk factors, the probability of a 5-year recurrence is 40%. So, even with no risk factors, relatively high, but with the chance of progression is 0.6% and a 5 year is 3.4. So, and again, escalating from there and then using because of that, kind of increasing levels of intravesical therapy, kind of aggressiveness to treat mainly the recurrence and, potentially the progression risk.
Yeah, absolutely. And exactly. I think just counseling and presenting that information as we have it to our patients and framing that issue as we're not trying to prevent this cancer from killing you. We're trying to prevent this from continuing to be an issue or a nuisance for you with bleeding recurrences. But acknowledging, of course, that there's a huge burden on the patients with all of these things that we are offering to them, trying to make them better. It's really causing quite a bit of work on the patient. So next, I want to move on and really talk about all of that work we put our patients through, right? When a patient has a recurrence, like we just discussed, we usually recommend a transurethral resection to properly stage that recurrence, make sure we still keep them in that intermediate risk group, which we think they fall into, or maybe they're newly in that intermediate risk group with their first recurrence. Generally, they go through that TURBT, usually recommend intravesical perioperative gemcitabine. And then we talk about, do we surveil this patient just with cystoscopy, or do we offer intravesical therapy options? So, Erin, can you talk us through what some of the strengths and the limitations of our traditional intravesical therapies look like in that paradigm of offering them adjuvantly after a resection?
Yeah, it can be a complicated space because there isn't sort of a black and white answer here in terms of which agent we give them. And then with the BCG shortage compounding everything too, and from a resource allocation standpoint, shifting more and more to these chemotherapy type agents. One upside to them is that typically they're very cheap, and so from a hospital system and patient perspective, they're easier to obtain. They're just given intravesically as opposed to systematically. So from a side effect profile, it tends to be better tolerated, but you still can have some issues here. Mitomycin, for instance, you can get chemical necrosis, and if that happens, it can be pretty debilitating there. Gemcitabine is a little better tolerated in that regard here, but you can still get sort of this dysuria and burning, and even some like minor flu-like symptoms there too. So you have to take that with a grain of salt. The other thing too is that a lot of the data supports that it may be better from an induction standpoint, but the longer you continue these, the durability of response is less established and probably less effective there too. So you have to take that into consideration. And then lastly, it's just about burning bridges. You know, in some regard, you want to save some of these modalities for later on. If in fact they do progress, if you're getting all these chemo agents, one on top of another, you give mitomycin, it recurs, you resect, then you give gemcitabine. At some point, this toxicity can build, and bladder changes from a result of that as well.
Absolutely. I think the changes on the bladder are really important to consider because it causes more lower urinary tract symptoms for our patients. Now they're having to start other medications. Now you're getting into that multiple recurrences, maybe polypharmacy added on top, and you really start to worry about the burden, the cumulative burden of this disease for our patients. Now, there is evidence to use adjuvant therapy. Obviously, like you said, we want to be judicious about it, certainly from a BCG conservation standpoint. But the reason we do it, right, is to reduce these recurrences with the hope of reducing the exposures to the healthcare system for the patient. So we're talking about 60, 70% recurrence-free survivals for patients who undergo these adjuvant therapies in that mitomycin, gemcitabine arm. There is some retrospective data using gemcitabine docetaxel in this space as well, pretty similar, about 71% recurrence-free survival at 2 years. Slightly better numbers for BCG, maybe 60 to 70% in the intermediate risk space at 2 years. But I agree, I think most of us have been trying to not use BCG in the intermediate risk space, especially because of the shortage. And part of the reason we want to do this, obviously, is to improve that recurrence-free survival. And to help us in this space, we've had an explosion of clinical trials in that intermediate risk space to give us more options. So, Pauline, can you talk us through a little bit about what patients you might consider a clinical trial for as opposed to the traditional paradigm that Erin described?
Yeah, so we'll talk specifically about this UGN-102 and that clinical trial results and patients that were included in that and when to consider it. But I think the main thing now is that there's going to be a lot more coming out in this space than we currently have, and it's a super exciting time just in the short term future for these patients. So I think considering and most of the active trials are considering patients that have papillary disease that is either treated or untreated and you're trying to avoid the operating room with, so a chemoablative type treatment. And so we'll talk some about today, but there's so many different options pending on the different characteristics of the patient that different people have available and are currently enrolling.
Absolutely. I think it's really exciting that we're going to have more options. I mean, obviously, we have options for these patients right now. I think it's challenging because of the burden that some of these options place on the patient. So having options that may require fewer visits could be helpful. So Able 22 is looking at using nadofaragene, which is a every 3-month installation. Moonrise 1 is a trial looking at using the TAR device. So that's an every 3-week potentially installation, or even longer actually for that particular one. Maybe Pivot 6 is using cretostimogene in the space, and then of course Envision with UGN 102, the chemoablative option that we will discuss now. But before we get into that, I really want to talk to Meredith here, because what a lot of patients will start to say is, these therapies are really starting to bother me. I have more urinary bother from them than I did 2 years ago. The last installation of gemcitabine, or the last treatment with BCG, really wrecked me, right? Or even the patients who at some point said, "Oh, I'd love for you to burn that off in the clinic. I don't want to take time off for the OR." Will come back and say, "You know what? Actually, that hurt a lot. I don't want to do that again." So, what tricks, tips do you have for our listeners with helping patients tolerate intravesical therapy installation? I know you do these. I know you monitor their side effects. You have a lot to teach all of us.
Mhm. Yeah, how long do we have? I could talk about this forever. So I think everything you said is exactly right, and is perfect to point out once again how different every patient is with what they hate, what they prefer, all of that. As far as managing side effects of intravesical therapies, um, same thing. Everyone is really different. Some patients have a really hard time holding it for the recommended dwell time. Some patients have horrible frequency, urgency, dysuria, hematuria for the first 24 to 72 hours. Some patients, when they start therapy, they have no side effects. We love those. Some patients have start therapy and those 6 weeks, they have horrible side effects. So it depends on the patient, but most patients I end up starting on atrospium or myrbetriq or Gemtesa. I would say I use trospium or one of the anticholinergics the most because it starts working quicker. And again, some patients I will start it and say, okay, you're going to be on this for these 6 weeks, and then we'll reevaluate if they have the frequency and urgency, just kind of regardless. Some patients, if they have a hard time just holding the treatment for the recommended dwell time, then let's say if they're getting their treatment on a Friday, then I'll have them start taking their trospium Wednesday evening or Thursday morning. Um, some of the patients who really have a hard time holding it, who might just have true incontinence or post prostatectomy incontinence, or a lot of the women have a hard time holding it. Valium suppositories can be really useful for that.
I have
Um,
heard about this. These need to be compounded, I think, by a
yes,
compounding pharmacy, but they seem to be incredibly effective.
yes, yeah. It can be tricky to find Valium suppositories, so I'll also use belladonna or BNO suppositories. One tricky thing with using with Valium or the BNO suppositories, patient has to have a driver. So
Yeah.
that can be one more logistic for them. Some patients, it's really not about their bladder, but it's just truly it's anxiety. They have a lot of anxiety with coming into the office, and the thought of getting a catheter. So I'll even do PO Valium. Um, Kind of a real trick of the trade. Some patients who have a hard time, who just cannot hold their treatment. And this oftentimes ends up being patients with maybe some dementia. I can think of one patient right off the bat, we would put the treatment in, and I think as no matter how many times I explained it, she thought she was supposed to pee it out. So what I started doing was put the Foley in, put the treatment in, attach her Foley to a bedside bag, and hang the bedside bag above her head, neck on an IV pole. So that way, if she spasmed or tried to start to pee, the urine, the treatment would go up the catheter bag tubing. And then when her bladder calms down, it comes back down into her bladder. It's not perfect, but that has worked really great for a lot of patients. Um, and the last thing, just kind of a plug where I think I know I can do better. I know probably across the country we can all do better is our women with non-muscle invasive bladder cancer. Most of these women are postmenopausal, and we probably have all seen the AUA has updated guidelines on the genitourinary syndrome of menopause. So a lot of these women have a lot of urinary symptoms already from vaginal atrophy. They have a bladder tumor that's going to make these side effects worse. And then they just have, and then we're giving them intravesical therapies, and that's going to make all of this worse, all of those symptoms worse. So, trying to get these women on vaginal estrogen cream early. And that's something I need to work on. And I think we can all work on, because that can really, um, that can make a big difference for a lot of women. You know, a lot of these women are so uncomfortable down there, and we're making that so much worse. And vaginal estrogen cream can just be a lifesaver. And it's, you know, I'm evaluating them. I'm doing an exam every week, so I can see what's going on, and the doctor doing the cysto can see we got some work to do. So that's a lot of information, but I love to talk about it.
No, I think that's phenomenal. And this is the information we're all here for, because this is the practical advice that I think we could all benefit from. This is kind of that crowdsourcing of expert tips. Erin, Pauline, anything to add on your experiences or anything else that you've come across that has been helpful with managing intravesical therapies?
I think the only thing I'll add is pelvic floor physical therapy can sometimes be super helpful in these patients, especially the
Yeah.
younger ones that have more control and able to go to a regular physical therapy appointment. Doing stretches or exercises in this space can help with pain and also with holding the urine or holding the therapy in more. So that's the only other addition I thought of. But those recommendations were awesome. I was taking notes.
Yeah, I completely agree. I think pelvic floor dysfunction is really underdiagnosed in this population, and sometimes it can really be a side effect of everything we've put their bladder through, that muscle tone just changes, and they really do need a lot of help trying to get back to a healthy, functional bladder. Absolutely. Well, we've alluded to UGN 102 several times so far, talking about the alternative to our traditional pathway. So why don't we get into it a little bit right now? And Pauline, can you walk us through the phase 3 Envision trial looking at primary
Ab-
chemoablation of recurrent low-grade intermediate risk non-muscle invasive bladder cancer?
Absolutely. So, okay, let's start with what is UGN 102. So, like you said, single arm, open label phase 3 trial looking at this reverse thermal gel that's containing mitomycin. So, it's basically a liquid when it's chilled. And then once it's warmed to body temperature by instilling it into the bladder, it becomes a semi solid, and it's got metamycin in it. So it dwells in the bladder. I think the release time total was about 6 hours, and basically creates this sustained release exposure to the bladder of mitomycin. It's delivered once a week for 6 weeks, very similar to the BCG induction kind of, you know, um, schedule that we're used to. So, who was included in this trial? It was patients that had at least one prior episode of low grade non muscle invasive bladder cancer. So, they recurred and they had a biopsy proven low grade disease, no high grade disease, and a negative cytology.
And they couldn't have had intravesical chemotherapy within the prior 2 years and or BCG treatment within the previous year.
They included patients that had multiple tumors, that had tumors greater than 3 centimeters that were low grade, that had early or frequent recurrence within the last year, but you couldn't have had all three of those things. Um, And basically, they looked at complete response at 3 months for patients that had these tumors that were not taken to the operating room for resection of those tumors. They were biopsied, but they weren't removed. And they defined complete response by, cystoscopy, by biopsying, making sure any new lesions were not high grade, and by a cytology that was negative. So
It included a total of 223 patients that got all 6 doses of this.
reverse thermal mitomycin gel. And the majority of the patients that were included in this trial had multiple small tumors. So the total tumor burden for most patients was around 2.5 centimeters, split up with under 1 centimeter tumors kind of peppered throughout the bladder. That's the majority of patients. So in the results, they found that at 3 months, there was an 80% complete response rate. So patients that had these recurrences had essentially response that had them go away and none new recurs. And then at 12 months, of those patients that had a complete response, 82% of them had durability in that response, which is a great number. Of all the patients that had maintained complete response, about 61% of them at 15 months had it, and the disease-free survival of this cohort was 76% at 15 months. So patients did really well with it. And in terms of adverse events, majority of them were, moderate or mild. The most patients that had treatment-related adverse events were things that are common also with BCG. So dysuria, hematuria, UTI, fatigue. Only 14% had a grade 3 or higher adverse event at all. The majority resolved. And there was only 2 patients that had treatment-related serious adverse events. So 1 urinary retention, 1 urethral stenosis. So overall, a well-tolerated, effective chemoablative strategy for this group of patients.
And Erin, we talked a little bit earlier about the fact that there were a couple trials done with UGN-102, Atlas and Optima, and then those were terminated, and then Envision was the one that was the one described by Dr. Philippou that we have data for. So what do you think the limitations are of the data that we have here?
Yeah, so I think you need to also take into account these other trials as well, because the Envision trial is great in showing that you can get a complete response, but the question becomes, in a single arm trial like Envision, is that enough to really establish efficacy? You had Atlas, which was a randomized controlled trial. Now looking at UGN-102 versus TURBT, but the accrual was slower than intended, and they only accrued about 44% of the patients, and so it was terminated early to sort of repurpose their mission and open Envision here. So you have to take that into consideration here, I think, to better assess here. So they did have a 77% complete response here at 3 months. But the question is, with the natural course of this disease, would that be expected later on just naturally? And without a randomized controlled trial here, it's hard to know. The other thing too is that when comparing to TURBT here, there wasn't a chemotherapy. There was no like standardized use of chemotherapy in that control arm either here, which just leads to more inconsistencies in the interpreting this data here. So I think you really need to look at all that. And then another avenue here altogether is that because this is an indolent disease process here, our follow-up data may not be long enough to know, is this really effective in preventing future salvage therapies here? You may prevent one TURBT, but downstream of that, are you preventing anything more? And we just need more data there.
I agree. I think duration of follow-up is going to be really critical here because, like we all talked about earlier, this is a lifelong disease for a lot of patients. And so a 3-month recurrence-free window is lovely, but is not nearly as meaningful as a 2-year recurrence-free window, which unfortunately we just don't have enough data to be able to comment on the durability that we care about in this patient population. And certainly looking at, does this in any way enhance their ability to respond to therapies down the line or detract from their ability to respond to therapies down the line? We really don't have the answers to those questions. I agree with you. I wish we had a TURBT comparator arm to really evaluate this data with. I think that would be really helpful to me as a clinician. And because of that, I want to pose the question to the group. Obviously, this is now an approved therapy. It's a chemoablative therapy, so it's designed to avoid a trip to the operating room, but still treat the patient's tumor, so not active surveillance of this tumor. Do you think this will replace TURBT for certain patients? I'll start with you, Aaron.
I definitely do. I think just because of the onerous nature of going to the operating room for some of these patients, not everyone has access to a surgery center. There's limitations from insurance. There's other out-of-pocket costs. I absolutely think that for select patients, this will prevent TURBTs, and patients will look at that enthusiastically. So
And
I think there's a niche here.
and Meredith, to really piggyback on your expertise here a little bit, which patients?
Yeah, I think both ways. Some patients really hate going to the OR. Some patients really hate coming to get their treatments once a week. And if it's someone who is incontinent, and then maybe they need to be on the TURBT plan. If it's a patient who is on anticoagulation and it's high risk to come off, or they don't have good access to a surgery center, or they don't have good transportation options, whatever it might be, then maybe using UGN 102 would be a good option for them.
Yeah, I certainly think it's something to be discussed and to consider, and trying to figure out who that patient population is going to be is really going to be the crux of this for our
Mhm.
patients. And also realizing that for some patients this would be a reasonable option, but there are many options that we've had that are effective and have proven track records in this space. So let's try to go through this a little bit with a patient example. So you have a 78-year-old man with 3 prior TURBTs in 2 years for low-grade TA disease. His latest cystoscopy shows 2 new papillary tumors. He's reluctant to go back to the operating room. Based on the data that we just discussed with UGN 102, how would you approach treatment, and would you discuss UGN 102 in this patient if this was available in your clinic? Aaron, based on what you just heard and what you just discussed on the trial criteria, is this patient appropriate for UGN 102?
Yeah, I definitely think he can be here. If you go back to Pauline's criteria earlier on the IBCG and trying to further break down who exactly is intermediate risk and what their risk within the intermediate risk is, I think that can sort of help here. If you're more worried about the potential tumor biology and being more of the path being upstage, I'd be a little more hesitant, because you would want tissue there to confirm the actual diagnosis and no progression there. But in someone such as this patient here with low-grade TA disease, I think he could be a great candidate for it. This is a little aside, but I think of my uncle who needed a procedure here in town, and he's so averse because of his anticoagulation to doing anything. And I'm sure he can come off anticoagulation. I'm sure he can, but in his mind, he can't, and would do anything possible to avoid any type of resection here. So I think in a patient like this, as long as it's available, I think I would bring it up with them.
And Pauline, how would you counsel a patient who is eligible for UGN 102, but also eligible for all of the traditional approaches we discussed? He could get a TURBT, he could get follow-up gemcitabine, docetaxel, mitomycin, even BCG if you thought it was appropriate. How do we help a patient make that decision, and what factors, whether they're clinical or personal, do you think weigh in more on that?
Yeah, I think, being honest is really important in this space. Being honest that we don't have that much data in terms of longevity about UGN 102, what that looks like in the long term. that, in a managed care organization like myself, I don't know when I'm going to have access to UGN 102 because of cost and because of that lack of long-term data. And so, talking fairly about the other options that have been more parsed out in terms of longevity and efficacy, and talking about a TURBT, what it looks like. I mean, he's been through them 3 times now, but in a 78-year-old, knowing what we know about anesthesia exposure and dementia risk and brain fog and all the things that come along with the TURBT, weighing that in and kind of, getting a sense of what they want. I'll also put a plug in. Don't forget about upper tract imaging to restage these patients, especially if it's been a
Absolutely.
while since they've had a recurrence. It's not uncommon that I've found upper tract tumors that are seeding the bladder, and obviously how you manage that is completely different. So, and unfortunately, there's a lot to talk about in this space, but really getting patient input as to what they're worried about and what they're hoping for from their treatment. Asking a patient, what is your goal with this next step that we're talking about? And sometimes that can really tell you a lot about what they're hoping for and whether the treatments that you have are going to meet that goal or not.
I agree. I think engaging in shared decision making from a clinical counseling standpoint is tremendously important. And also making sure that the patient really is at the risk that you think they are. So using cytology to maybe rule out the presence of high-grade disease and making sure you are up to date with upper tract imaging is really important to make sure that you are offering the patient the treatment for the disease that you think you're offering them the treatment
Mhm.
for. Meredith, since this is a new therapy and this would something that could be integrated in some of our clinical practices, what challenges do you think might arise with integrating this new treatment paradigm that is 6 visits, so more patients potentially coming to our clinics, taking up clinic time and space,
Mhm,
patients
mhm,
that used to be in the operating room?
mhm. Yeah, of course, there's always going to be growing pains with a bringing in a new therapy. Um, and I mean, just in the last, I mean, what, 1 or 2 years, we've had so many new therapies. So I feel like we're getting to be a pro at bringing new therapies to the institution. Um, I'm really lucky that I work at a large academic center. And so I have a specialty pharmacy who handles a lot of the insurance and cost and payment stuff. And then I can just educate myself on the administration and how we're going to give it and the logistics of giving it to patients. Um, Now, as far as more volume of patients, that's kind of a constant battle between myself and and our administrative team, where you know we have the we have volume. A lot of patients have bladder cancer, and we have to be able to tend to that. We currently we're doing about 50 to 60 intravesical therapies a week, so um, hopefully bringing in a new therapy that isn't going to change a lot. But with so much of the landscape changing, with again Adstiladrin being once every 3 months, that's a lot different than when those patients were getting um BCG or gemcitabine docetaxel. So it's all evolving and changing, so hopefully it won't be a huge growing pain for us.
Yeah, I agree. I think we've all learned to adapt, whether it's to new treatments or new duration of treatment, right? When we started using Gemdosi, we had to adjust how long we were going to use clinic rooms for. And so I
Right.
think that this is something that we certainly are capable of in our clinics, but it probably won't be without its own initial hiccups as far as figuring out how are we going to administer this, where do we store it?
Yep.
Is it in the refrigerators in clinic or is it downstairs? When do we send for it? Those are the logistical things that I think will have to be worked out.
Right. And I know I'm very lucky. We have a great relationship with our chemo pharmacy. And so we've been doing Jelmyto for years now, and I imagine it'll be a pretty similar process to that, where we're constantly in communication, and with Anktiva and Adstiladrin, same thing.
So there's a question that we got in the chat that I think Dr. Philippou can help address a little bit. Is there evidence on multifocal versus localized tumors in regards to response to UGN-102?
Yeah, so the majority of the patients that were enrolled and thus responded were patients that had multifocal disease, but each of those disease sites were relatively low volume. So smaller, more multifocal tumors was the vast majority of the patients that were involved in this.
Thank you for adding some clarification with that. So let's kind of address the elephant in the room a little bit, right? So this is now approved. It is available commercially. What do you think it would take to make this a first-line therapy? As a percentage of all of the patients we see with intermediate risk space, do you think that we are going to transition 50% of TURBTs to using this, 5% of TURBTs to using this? How do you think this landscape's going to change in a year? Obviously, I'm making you all to make a prediction right now. I know nobody knows the future, but I'm just thinking for myself, we have some clinical data. We talked about how it doesn't have the duration that we'd like to have, and we don't really know how it's going to roll out with patients being able to tolerate it, and are they going to be happy down the line? We'll talk a little bit about patient experiences in our next segment, but does the patient experience of saying, I'd love to avoid a surgery, is that enough for us to change our practice?
I think the ramp up here is going to be interesting. It's if you look at this panel here and all of our different working environments, they're so distinctly different, and so I think the availability of this alone is going to vary widely, and so patients may come in with an expectation, let's say, of wanting this medication, but it may not be available. It probably won't be available in my clinic for 5 years. As I can't give a chemotherapy agent in clinic, I have to send them to a medical oncologist and get it set up there. So I do worry that the ramp up time is going to be maybe slower than anticipated. So if you're going to make me throw a number out here, 365 days from today, I would say it'd still be pretty low, 5 to 10%. And then that will increase with time.
And you think predominantly based on the rollout and the logistics of potentially administration?
That and just patient perception, I think, will change with time. I think initially to tell someone, especially this younger population, we're going to watch it, this is going to dissolve it without cutting it out, something that a lot of these patients are used to. I think until we get this sort of new age of patients with de novo tumors and then the recurrence, I think that'll take some time.
Pauline, any difference of opinion, or you think in line with what Erin is thinking?
Yeah, in line, definitely. I think that, and I'm jumping the gun a little bit, but I do think that patients that are exposed to this want it. When you look at Atlas, for example, with the trouble accruing, you always have to ask yourself, what is it about the patient that doesn't want to enroll in this trial? And when you give them the option of this chemoablative therapy versus a TURBT, and they don't want to have the choice or the chance determine which one of the two things are going to fall under, you wonder, and especially with the patient reported outcomes showing that most patients, when encountering UGN-102, prefer it. I think they're going to be asking for it, but again, the rollout, the cost, I mean, that's something we haven't addressed yet, but it is a costly medicine like most of these, newer therapies. And I think the rollout is going to be slow for all of those reasons.
Meredith, and then just going back, I feel like I'm asking you the same question in 3 different ways. From the patient perspective, what do you expect? Do you expect patients are going to be asking about this, or do you expect more hesitation on the part of the patients, especially knowing that I like Erin's point about the de novo intermediate risk or the experienced intermediate risk patients. I think there might be a difference there between the patient populations.
Yeah, yeah, that was a great point that I had not thought about. With patients who are used to, there's a tumor, we go take it out. I agree. I think it'll be slow, and I know in our population of patients, we really see a wide range. Patients come in very educated on every therapy available for non-muscle invasive bladder cancer, and then patients who have never heard these words before. Um, so it will be interesting. It'll be interesting to see.
Well, certainly. I think we're all going to find out with some time, so this won't remain
Yeah.
mystery for very long. So we've all sort of talked and alluded recently to the patient experience aspect of this. So let's talk about that a little bit. There's a recent paper looking at the patient experience with UGN-102. So Aaron, what did we learn about that? What do we know about patient preferences when given a choice between TURBT and UGN-102?
Yeah, so there's an interesting paper just published last month in the Journal of Urology assessing that they looked at 41 patients who completed interviews, but only 29 of them completed both interviews here. But if you looked at what themes emerged here, what they found is that these patients would perceive that TURBT interfered more with their routine and responsibilities, which makes sense, time off of work or needing a catheter potentially afterward. Urinary symptoms were quite similar, but the bleeding and catheter issues and time to resuming sexual activity also were longer with the TURBT. Now, the UGN 102 arm did have some rare reports here of what they perceived as internal itching and difficulty with keeping the gel during the installations. But in general, and now granted, there's probably a selection bias here, so we have to take that into consideration. But in general, these patients would recommend this as they perceived it to be less invasive and less painful, as well as less time consuming than a TURBT here.
Yeah, I agree. I think it's hard to know, obviously, with the percent response rate to the survey, you kind of get the sense that it's really the motivated patients that responded. It's either the people who really loved it or really didn't, and you might be missing all the folks in the middle who could have gone one way or the other. So I think certainly following up as the rollout of this occurs and we get more and more patient reported data in our clinics, I think we'll learn quite a bit about it. But on the whole, now we have to balance clinical efficacy that's been described in this trial and clinical efficacy that we know of all of our traditional therapies and this concept of patient convenience, right? Keeping patients out of the operating room, maybe a patient who prefers a clinic-based intervention. Pauline, how do you think we're going to help patients make those decisions?
Yeah, I think in the patient that I see this as being an ideal for is someone that has had several recurrences, that you are confident in your kind of assessment of the biological signature of this type of disease, right? That it's coming back low grade, that it's resistant potentially to prior therapies. And I think in those patients, UGN 102 could be a great option. Um, so I think knowing that it is low grade is a key thing. And sometimes it takes a couple of TURBTs or office cystoscopies with biopsies to figure that out. But I do think that there's going to be space for this in those patients that you do know that this is a low grade recurrence.
And Meredith, we talked about this just a little bit about the logistics of rolling this out in the clinic. Now, I imagine that some institutions are going to have slightly different costs for this than others,
Mhm.
but we know that a TURBT can be as low as a $20,000 charge for a patient. And this is on the order of $20,000 per dose times 6 doses.
Mhm.
However, if patients have a complication with a TURBT, if they get an infection or hematuria, those costs can add up with an emergency room visits or additional costs of treatments or admissions, possibly. Obviously, those things are quite rare. The cost doesn't seem necessarily balanced to me on the
Right.
offset, but Unfortunately, we live in a very expensive healthcare system, and we sometimes, as physicians, I think it's our responsibility to be cost conscious, but if a patient's insurance will approve a therapy and a patient wants the therapy is going to cost what it costs.
Right. Yeah, I completely agree, I guess, and this is where we are now with all of these new therapies, very costly, and working with, like you said, every institution is going to probably be a little bit different. Every insurance is going to be a little bit different. Um, but I think in a space with the UGN 102 where there are options, it will be a more nuanced discussion of considering the cost. If they need it, they need it, and that's what it is. But having more options to kind of have that shared decision making conversation, and can be a big part of that. Like you said, with the TRBT, sure, a TRBT might be $20,000, but there could be more costs that we can't predict coming as a side effect of that. Whereas with the drug, we can say this is what it is, boom. So I think it's one more piece of the puzzle of that shared decision making in this space.
And I think also figuring out for your clinic space, for your practice, is this something that's feasible? Can you deliver a chemotherapeutic? Does that help you as far as where your patients are being seen and how you staff your clinics? And does that fit well into your workflow? Or is this something that logistically would add more patients to your clinic space that you maybe can't accommodate for all patients, but you could consider for that select patient, especially like you mentioned, patients who are on anticoagulation, where you really do worry about the risks of taking those patients off their medications and the
Mhm, mhm.
logistics around that. So it's certainly to be determined in this space what the actual use and what the prevalence of it. But overall, as somebody who sees these patients and provides care for these patients, I'm super grateful to have another option. I think it's important for us to broaden the pipeline of things that we can offer our patients. I'd love for these things to be very effective. I'd love for them to reduce progression, recurrence, be super convenient, and be really cheap. But at some point, something's going to have to give, and we're going to see where that is all going to shake out. We have a little bit of time left, so I just want to take a few minutes to ask all of you, what do you think is missing in this space, in this intermediate risk space? What were you looking forward to? What do you think would be the holy grail treatment? Obviously, I said I wanted to be cheap and administered once a year, but tell me what you guys think.
I'll take the first crack here. I think something that we haven't talked a lot about either is just the convenience factor from where these patients are coming from. We all take care of patients from so far away, oftentimes where transportation issues can be a real thing of having to come back once a week for 6 weeks. And some patients will flat out refuse that for good reason. And so from a holy grail technique, it would be something to minimize the frequency of these treatments. I think would go a very long way. When telling some patients that they have to come in every week for 6 weeks, it's just too much. They need a family member to take off work, and it's a day of lost salary, and that can add up.
I absolutely agree. Before I give you two a chance to comment, there's actually a comment in our chat, and maybe you can speak to that a little bit. Low-grade papillary bladder tumors are a surgical disease process. With frequent enough surveillance, small recurrences can be treated safely and effectively with office fulgurations or straightforward TURBT with minimal anesthetic risk. Initial TURBT should have the goal of complete resection for diagnostic and therapeutic purposes. So avoiding this is not something we should be considering as a field. This is an expensive therapy with its own significant quality of life risks that has a very narrow indication, generally speaking. Intermediate risk, low-grade bladder cancer in and of itself is something that probably doesn't exist biologically. Pauline, what do you think about that? What do you think about the idea of office fulgurations or straightforward TURBT in this space? I do want to comment that an initial TURBT, a diagnostic TURBT, is necessary to establish the disease grading and staging for the patient. So you want to have that information. This is to make the patient intermediate risk, has to be a recurrence almost by definition.
Yeah, I agree. I think it's a good point. I completely agree that initial 2 RBT, we should not be trying to avoid it as a group. I think that's a slippery slope that I don't think any of us are arguing for. I don't know that if low grade intermediate risk is a surgically treated disease when it recurs. You know, we have these examples of patients we do go to the OR for, and we scrape everything out that we see, and they come back and they've got recurrence. And so I think this medication and this space is looking for other options to try to address that in a non-surgical way because of the the failure of surgical treatment to sometimes manage this disease. Um, so um, in some ways, I agree that we shouldn't be trying to push the limit in terms of diagnosis, but in terms of recurrence, I wonder if there is space for this.
I agree. I think that there's a lot to consider here, and about balancing, minimizing risk and morbidity to the patient with 6-week visits for something that we could potentially, zap in the clinic right then and there that you're seeing the patient. If we're talking about using this therapy to reduce patient risks or trips to the operating room, there are often clinic-based interventions that we can consider, but there is certainly a role to develop new treatments, better treatments, to see if we can manage this disease better 5 years from now, 10 years from now than we have been up until today. And with that, this concludes our panel discussion for today. I want to really thank my participants, Erin Laviana, Meredith Donahue, and Pauline Philippou. Thank you so much for all of your contributions. Thank you all for joining us this evening.